Good morning, everyone. I'm Dave Roth of DuPage Federation. Welcome to the 2023 Forum, Best Practices in Collaboration to Strengthen Healthcare with Immigrants. Our goals today are to share best collaborative practices to strengthen healthcare across all of our sectors. And we're very fortunate today that we have represented in our audience healthcare providers, public health offices, schools, funders, legal services, mutual aid networks, elected officials, employers, libraries, municipalities, and more. These are the groups that we want to collaborate to strengthen healthcare. We also want this morning to inspire continued commitment and cooperation in our work together. This morning, you will hear, number one, a panel featuring 4 different kinds of collaborations from across our region, from as far north as Lake County, as far west as Kane County, and as far south as Will County. We'll also feature an advocacy and policy update from Luvia Quinones of the Illinois Coalition on Immigrant and Refugee Rights. We'll do some work together. We'll go into small groups, breakout groups, to share our own best practices and to apply what we've learned from our presenters. We will finish our morning with encouragement from young leaders in civic engagement coming to us from the Southwest Suburban Immigrant Project. We thank the Illinois Department of Human Services for support for us to be able to do this forum today. All that we do today is going to be shared with you and others in these 4 ways. The meeting is being recorded, and that recording will be shared. PowerPoint presentations will be shared. The resources that through this morning are posted in the chat, we'll edit that chat and we'll share those resources. And as we break into smaller groups, those groups will use Jamboard to collect ideas, and we'll share the results and the contents from those Jamboard tools. All of these are going to be available to you through a landing page at dupagefederation.org. Later in this event, we're going to ask for your feedback about the forum. We're going to drop a link in the chat and ask you to click on it, and we think it'll take you 2 minutes or less to give us feedback. During our presentations, do ask questions. And do that, please, by placing them into the chat, and help us note your questions when you place them there by beginning them with a double hashtag. Hashtag, hashtag, then your question. That's how we know it's a question for the presenters. So let me check one more time to see if Luvia has joined us. Luvia, are you with us this morning, or shall we move directly to our panel? Okay, hoping the best for her and her arrival soon. So I'm very, very pleased to present to you 4 community collaborations that are actively strengthening healthcare among immigrants. Some of them are working at the community level, some at the municipal level, some at the county level, and some at the regional level. We're going to introduce 4 panelists. Each panelist will share for 5 to 7 minutes. If you have questions, please offer them in the chat. And as I suggested, please start your question with a double hashtag. And when the 4 panelists are finished presenting, we'll go to the questions. Rosa will be monitoring the chat, and Beth will be working with her to do that. So it's my privilege to invite to the microphone Sarah Phelan. Sarah is the Executive Director of People Made Visible and a strong leader at Healthy West Chicago, along with many other leadership roles in the community. Sarah will share with us her community collaboration. And Sarah, are you able to advance your own slides, or would you like for, okay, good.
I can do that. Thanks, Dave. And so happy to be with you all this morning. I think this is obviously a huge topic, but I'm going to focus on what we have been working on here in West Chicago through People Made Visible, and then one of our programs that's a collaborative communication program around health, Healthy West Chicago. So West Chicago, I really think this is an important point to highlight, and we always start here in this discussion about our community being a historically diverse community. What does that mean for us currently? It looks like the Latina population, which is mostly made up of Mexican Americans, is at 53% of our population. But it's important to note that our school district is at 80%. So when we look at what health looks like in our community, to also focus on the younger generation, we have a much larger population there. And I have this picture here. My day job, I'm the city museum director. So it's really important for me as we look at trauma-informed practices in healthcare, that we also look at what generational trauma impacts health. And that definitely includes our historic immigrant population. So here in West Chicago, we were a German English bilingual community first, and then a Spanish English community for well over 100 years, actually almost 110 years at this point. Our first immigrants were housed in boxcar camps, and then we had the longest operating company town in the state of Illinois with the Campbell Soup Mushroom Farm in West Chicago. So what do those historical populations mean when we look at today's health and how that impacts our community? We also know that, and hear a lot, that DuPage is one of the healthiest counties in Illinois. But in West Chicago, we are definitely an outlier. We have some stats here around community need, but we see huge rates of chronic obesity, chronic disease in our community. And so when we look at that lens of Healthy West Chicago, what can we do that goes beyond what we know is happening with medical professionals that are very taxed for time and resources? So People Made Visible, where I sit in the nonprofit that I co-founded in 2009, we see ourselves as a community incubator, and we serve as the nonprofit umbrella for a couple different programs that happen in West Chicago. Something that I think is important that I wanted to point out is we are community led. So our board is made up of community residents, which allows us to give that further insight into what's happening in the community. And then we also serve as an artist incubator. So we bring in teaching artists, other socially minded artists who do programs like our sensory walking program, which we did shortly after COVID to allow people to experience healthy practices that maybe have a little bit of different bent to them than just come out and walk for health reasons. Healthy West Chicago sits within People Made Visible. We serve as the fiscal agent, but as you can see from this slide, we are a huge community collective. We have a core group of around 16 participants that does include medical professionals, healthcare professionals, but also the major stakeholders and organizations in the city of West Chicago. And we run a very robust program schedule. We do nutrition, very heavy nutrition specific practices, as well as making sure that we're offering free and accessible physical activity. And we also work on different things that are systematically throughout the community. So when it's brought up that there are walking trails that aren't accessible, that there are places where people are feeling that it's not going to, we also approach that through an advocacy lens. We also have here what I have termed accessible and health in parentheses, or here about our programs, because we also understand the health mind body connection and how important it is for community placemaking and for people to feel that they are welcome in a community so that they also feel that they can reach out and ask for help, ask for questions. We can better understand needs. We do run an extensive yoga in the park program, as well as walking tours that we do and walking programs. We do quite a little bit with the schools as well, where we go into the schools is again, going back to that youth population and how are we best approaching and reaching families where they are. And then we also run a community garden program in West Chicago with partners on the ground. For a while, this also involved the Garden Works project, if anybody is familiar with them, that provide healthy gardens in homes as well as to people who qualify. And then again, bringing it back to this mental health connection. From an organization, nonprofit perspective, we are not medical professionals, but we know that there's a huge need in the community to get access to healthcare. And this also means mental health. We work really closely with our school district, and we go together for kids, one of our school-based collaborative that deals with birth to the end of high school and families. And we know that there's a huge backlog in mental health. So if people are stressed, especially as we deal with the new normal in 2023, what does that look like? How are people finding connections in the community? So we also host quite a few mental health oriented art workshops for the community. This allows for people to not only come together, have a place and a feeling, but to also be in a space where they can also feel that they've accomplished something. We do mental health grounding at the beginning and the end of these programs. And then something that we know is vitally important to the work that we do is trust building. For an organization to go into a community, even knowing that we are community members, there's still always the barriers to trust and to make sure that people understand that we're speaking their language, that we're also doing things that are culturally appropriate for their community. And that's something that we do quite a lot with Healthy West Chicago and then through People Made Visible. But we're also really advocating for that with all of our partners. We often hear of issues within the medical health field that isn't always understood from that high level, again, of that trauma-informed, history-informed aspects of why somebody might not be reaching out for help or why there might be distrust within the medical field. So that's something that as a community, we see ourselves as a way that we can advocate to break down some of those barriers and to make people feel comfortable. Again, these are projects that don't necessarily seem exactly aligned with the health needs that we see in the chronic health that we see in our data, but it is ways that we're able to into the community. So if we're hosting and somebody comes to an art workshop where they might feel a little bit more comfortable coming and doing something that feels more accessible, then when we host a pop-up vaccination clinic, they already know us and they're willing to come and do that. So it's ways that we make entry points into the community through these programs. I'm going to stop sharing there. And thank you so much.
Yeah, Sarah, thank you.
I'll also drop our Healthy West Chicago link into the chat for people who are interested in the robust programs that we're running.
Okay, your presentation inspired a lot of ahas in the chat of those who are living or grown up in West Chicago and those doing similar work elsewhere. I want to remind attendees, go ahead and put your questions for Sarah in the chat. We're going to move ahead and listen to our other three panel presenters, and then we'll get to those questions when we finish that. I want to invite to the mic Kara Murphy of the DuPage Health Coalition.
Good morning, all. I am Kara Murphy, president of the DuPage Health Coalition. So happy to be here this morning. And Dave asked me to talk a little bit about one of the programs, two of the programs actually, that the DuPage Health Coalition coordinates. For those who are unaware, the DuPage Health Coalition is a 21-year-old organization who coordinates health access for low-income, uninsured, and underinsured residents of DuPage County. That is our mission, remains our mission. But in the last several years, we've become increasingly focused on a new topic, an enduring topic for the county and for the nation, but a pervasive and growing need around the issue of medical debt. And I know that Luvia is going to talk more about some of the policy recommendations and also some of the legislative agenda on this topic, so I'll leave that piece to her. But we want to talk a little bit about some of the interventions that we've been putting in place here in DuPage County. First of all, why is medical debt an area where we want to focus some of our time, energy, and attention? First, it's pervasive. Medical debt can happen to almost anyone in the United States. All of us on this call know someone. If we ourselves have not been challenged by medical debt, we know individuals who have. But the debt is most pronounced among people who are already struggling with poor health, with financial insecurity, or with both. There's a projected about $200 billion of medical debt currently in the United States, and 4 in 10 adults currently have medical debt. 6 in 10 adults, this is a recent Kaiser study, that have healthcare debt say that they or their households had to cut back on basic necessities. And by that, I mean food, clothing, basic household items to try to pay down their debt. And half have used up all of their savings in an effort to do so. Medical debt, important for this conversation, is also a pervasive driver of health inequity. Families who have debt or who fear debt delay the care that they receive or defer care that they need. They're more afraid of the bill than they are of the consequences of the unmet healthcare needs. And 24% of white non-Hispanic Americans indicate that they have trouble paying their medical bills in the last 12 months. But those numbers are almost 50% higher among African American and Latinx neighbors, 31 and 32% respectively. We were curious and concerned that the data that we would see if we asked our members, those who are enrolled in our Access to Page program, our Silver Access program, and other DuPage Health Coalition programs, about their experience or their household's experience with medical debt. We wanted to know what they were currently struggling with. And so last year, about this time, we actually launched a text-based survey in English and Spanish to all of our members, and we got a really strong response to the survey, but the data actually was even more concerning than we had anticipated. Of the several hundred people who responded to the survey, and we asked people to respond whether they had debt or not. We weren't only asking for people to report on the debt that they had. But actually, of those that responded, 3/4 indicated that their households had current medical debt, and 54% of respondents had debt of greater than $1,000, with 26% having had debt that was greater than $5,000 or more. This is notable because the families that are enrolled in Access to Page and Silver Access have incomes that are very low. So those numbers, 1,000, 5,000, in some cases 20,000 or more, are far beyond the capacity of this family to be able to absorb into their typical household budget. We also asked if individuals that were responding to the survey would like additional resources or advocacy assistance to be able to support their efforts to address this debt, and 88% said that they would like additional assistance. And so with that evidence, we launched 2 programs that I wanted to talk a little bit about. In the first year of our medical debt initiative, we focused primarily on folks who are already enrolled in either Access to Page or Silver Access, or were living in households that we were already serving. And we hired a team of bilingual health navigators who reached out both to those who had completed the survey and to all of the members of all of our programs to invite those individuals who had outstanding medical debt to work with our team on navigating the process of applying for assistance through the hospitals, through medical clinics, through ambulance providers, and all of the other providers out in the community. We would work with any bill that they had. It did not need to be a bill that was generated in DuPage County, although we do exclusively serve DuPage County residents. But in fact, we have ultimately worked with bills that came from all over the place, and that was fine with us. Ultimately, in the first year, we worked with more than 700 individuals and more than 2,000 bills. And we were successful in having $4 million in medical debt written off by this program. Now, I want to stress that as pleased as we are with the results of this effort, clearly identifying a need that we were able to fill, more important is addressing the upstream drivers of medical debt. We would like to not need this program. We would like to find better ways of ensuring that people aren't straddled with that debt, and that they don't have to come up with Band-Aid solutions that create a way to discharge debts that really should never exist in the first place. So one of the things that we're also doing is taking a look at some of the policies and practices that we think are working poorly, unfortunately, to make it more difficult for families to successfully navigate existing charity policies, or that work against even well-intentioned efforts to have individuals who qualify for charitable write-off to receive those benefits. And there are a host of recommendations that are coming out of that effort, and we are working with our health partners out in the community to enact changes in existing policy and to build new policies and practices that we think will be more congruent with efforts to ensure that those bills are not continuing to saddle individuals who have no meaningful capacity to pay them and who their own practices and policies say should not be asked to pay them. The truth is, no one is asked to pay the full cost of healthcare except the uninsured, and that is an absurd paradox. I won't go into all of the details. Hopefully we'll have a chance in breakout session to talk a little bit more about it. But some of the fixes are easy. It's about simplifying applications, making sure that they're accessible and generously available, clarifying language, and removing components of applications that have a chilling impact on people's willingness to complete them. If assets are not actually a consideration for someone's completing an application for charity assistance, then don't ask them questions about their house or their car, because if someone believes that they're at risk of losing their house or their car for asking for assistance with that bill, they're probably not going to complete the application. Similarly, provide automatic discounts when you know that someone is uninsured rather than requiring them to ask for that discount. And come up with a common definition of what represents medical necessity, because one of the things that we've learned is that different organizations are defining necessity differently. And in fact, that's something that the medical community is actually pretty well established. That is, there is a definition out there and we should be using it. I know that time is short, but I do want to spend a moment talking about one other partnership that we've been working through this last year and look forward to expanding in the next year. And that is a partnership that DuPage Health Coalition has entered into with an organization called RIP Medical Debt. RIP is a national nonprofit that is funded by philanthropic efforts out in the community, among them Mackenzie Scott, who folks may be aware of as the largest philanthropic donor in the United States right now. The bright side of Amazon, I suppose. Mackenzie Scott provided them $80 million, as well as a number of other generous donors. And RIP has made it their business since 2014. They were actually founded by former debt collectors to purchase outstanding bad debt from hospitals and other healthcare institutions, and then forgive that debt and ensure that it's being taken off of the credit reports of the individuals who are currently being negatively impacted by it. It turns out that an analysis suggests that 70 to 80% of the individuals who have bad debt at a particular hospital likely have incomes at or below 400%, 4 times the federal poverty level, and therefore qualify for purchase of medical debt through RIP. And I'm excited to share that we have 2 very large health systems here in DuPage County that are currently partnering with us on a partnership to discharge the medical debt at their hospitals here in DuPage and around the metropolitan area. And we're also in conversation with 2 very large health medical groups in the community as well. This will have the consequence, once successful, of discharging millions of dollars of debt for thousands of patients with one stroke of a pen and some very busy IT people, which again is a Band-Aid. It's not the final solution to this problem, but it is a way to get at some population level improvement in the quantity of debt that's out there while we look at longer term strategies. Hopefully more discussion to come. Thanks, Dave.
Kara, thank you very much. Oh my goodness, that Band-Aid is worth $4 million that you've lifted in burden in the community, and it's a great clue to the impact we can make if we follow those policy changes. Thank you very much. I want to remind folks, if you have questions for our panelists, drop them into the chat, and we ask that you precede your question with a double hashtag so we know that it's a question for the panel. And I want to now invite Nancy Garcia Guillen to the microphone. And Nancy, would you prefer to advance your own slides, or would you like for us to do that?
Good morning, everyone. I think it would be useful for you all to help with the slides. I can go ahead and let you know when to go to the next one, if that's okay.
Very good. Let me open up the slides.
Perfect.
And I'll ask for your help to know when to advance.
I can do that. Thank you. Good morning, everyone. My name is Nancy Garcia Guillen, and I'm the Director of Civic Engagement with Southwest Suburban Immigrant Project, SSIP. SSIP just celebrated 13 years in May as a community-based organization and grassroots advocacy organization. SSIP serves Will and DuPage counties. In the chat, let me know which cities or counties you currently serve. Perfect. I see some responses. Okay, got it. So we have representation from different cities, each with its own unique challenges and triumphs. At SSIP, our work focuses on the experience of immigrants in the suburbs. Next slide, please. Southwest Suburban Immigrant Project, SSIP, also known as Proyecto Immigrante in Spanish, is a social impact organization led by directly impacted individuals and accountable to a directly impacted base. In other words, we are undocumented, led, and informed. SSIP is committed to community organizing for the rights of immigrants in Chicago's southwest suburbs through education, civic engagement, and advocacy, because we believe that by building up the power of families, we can win and overcome the challenges we face. Next slide, please. Here are some of the programs that we have at SSIP. We have more, but I just have a few here for your reference. We have our leadership and healing spaces, where we bring in community navigators and change makers to provide information to the public about different issues going on in their community. We also have a parent mentor program that engages parents in their child's education and outside the classroom. We have a mariachi program, Mariachi Matters program, that focuses on social justice through music, culture, and is specifically for low-income and immigrant children and their parents. We have the People's Clinic, which is an accessible legal representation option for community members here to connect them to resources and legal representation. We also have the Immigrant Family Support and Resource Program, which provides assistance to navigate key resources and public benefits for community members. And the last one that I want to highlight is the health justice work, which addresses the root causes of health gaps in the immigrant community through Know Your Rights and advocacy. Next slide, please. So thinking about some of the challenges, I wanted to emphasize and highlight 4 of them that I will talk briefly, and then we'll go ahead and talk about some of the solutions and best practices that we implemented at the organization, and then we'll go ahead and go from there, okay? So the first one is the demand for to meet other basic needs. Something that we encountered during our conversations with community members is that once we spoke to them on the phone or in person, we would realize that there was additional needs other than health access, that we would connect them to additional resources. Oftentimes the community members that were calling the organization or contacting or coming into the office would be impacted by ethno-racial trauma, which includes any type of violence, threats, or discrimination directed to towards someone just because they're part of an ethno-racial minority group. These experiences shape the perspective of affected individuals and negatively impact the access to other resources. And if this continues without healing, it may impact the ability of a family to thrive. So that's something that we're really conscious of, and different trainings that we have in order to realize some of those issues that come up with the families that we serve within our own community. The second one that I want to point to is language barriers. Although we have made great advances with providing different resources with across the state for different resources in various languages, there's still a gap in terms of the way that information is conveyed to community members in a simple manner in order to make sure that they are able to understand some of that key information. And that gap actually delays some of the services that community members need access to because they might not understand the complexity of the systems, which are actually the ones that implement some of those changes. The third one, if we take a look at the bottom, is internet access. Many organizations across the board realized during the pandemic that internet access or reliable access to internet was key in doing simple things for family members, like scheduling an appointment for COVID testing or vaccinations. So that was something that we had to help fill in the gaps, because if community members didn't have that access, it was going to be really challenging for them to make that appointment. And then the last one, the cost, the limitation of healthcare access. One of the options, one of the informations that we know for sure is that healthcare options for undocumented low-income individuals in the state is very limited. The state of Illinois was the first state in the nation to provide Medicaid-like benefits for seniors age 65, regardless of immigration status. Then we were able to win a second victory, which expanded access to people age 42 and up, regardless of their immigration status. This was a victory that was achieved by many community-based organizations across the state, including partners in this room, including you all. Okay. However, Medicaid expansion efforts for people over 42 years of age is currently under attack. What we have learned and proven over the years is that limiting access to consistent healthcare for everyone ends up costing us more in the long run. When immigrant community members have to go to the emergency room, they accumulate debt, or consequently, it affects their well-being of their children and their families. Let's go ahead and go to the next slide, please. Some of the solutions based on the challenges that I highlighted in the previous slide is it really does take a village. We relied on our partners. Relying on our partners has been crucial and essential in this work. Through this network, we have been able to connect community members to different resources, including COVID testing, PPE, food pantries, housing, and more. During the public health emergency, based on the new relationships that we created with partner organizations and also strengthening those relationships that we already had, we were able to create a resource index to centralize the different resources that are offered by our partners. This guide serves as a quick guide for our frontline team that answers phones to be able to connect community members to resources right after they contact the office. The second point that we focus a lot on is centering the client. In moments of fear, the need to provide education was key in anything that we did. This looked like providing immediate assistance and information to community members so that way they could understand what the issue was that they were encountering and coming up with potential solutions and having them help us think through the best solutions to the problem that they were facing. So having community members be actively involved with their own cases is crucial. We were also able to leverage and create an effective rapid response team to connect community members to resources through mutual aid and innovative events. We were also able to be mindful that an organized community also means that we have to be cautious and mindful that community members that are serving and are part of our frontline team need to actually have rest and figuring out what that looks like in terms of how do we actually combine all the work that we're doing and also providing rest for our community members, mostly for our staff who are part of that effort. The last best practice that we have is developing the strengths of directly impacted people. Again, we believe that people most directly impacted are the experts that we need at the table for any issues. Through leadership development and healing spaces, we center our stories as immigrants and find solutions via legislation and programming. For example, this year, the General Assembly passed a bill that would ensure no person at the ER goes without being screened for financial assistance. SSIP was part of this bill process after the medical depth work of our team and the stories we collected from our community members. Let's go to the last slide, please. Again, the takeaway: collaboration with other organizations is key, and our continued commitment to share our continued commitment to share knowledge. As an illustration of what shared knowledge can look like, I'm very proud to be joined later today by three of my colleagues at SSIP, Claudia, Maribel, and Adriana. While each in specific roles, they also form part of our frontline team. We will hear from them later today how they see our work in this moment and what is next for us to continue the advocacy for immigrant families. Thank you.
Thank you, Nancy. Oh, you've taken an incredibly complex and difficult world and brought focus on what's wrong and what we can do about it. Thank you very much. We have one more panel presentation that I'm really pleased to present to you. And I want to encourage you again, if you've just come on to the meeting, drop your questions for our panelists into the chat. And if you would let us know they're a question for the presenter by putting a double hashtag in front, we'd appreciate that. And now it's my privilege to introduce Carrie Rositas Sheftel, who is the Assistant Director of the Highland Park Library. And Dr. Rositas, I'm going to advance slides for you. If you give me just a minute to get those up on the screen.
Sure, thank you very much. Buenos dias, good morning to everyone. And thank you very much to the DuPage Federation and also to Luis, who's doing the interpretation for us this morning. And I'm gonna start with a bilingual story time. Well, not really. What I'm gonna do is, next one, please. I'm going to use and recommend a book that it's called Dreamers by Yuyi Morales, and I'm going to be inserting some pages of this amazing story. This book is an example of the role of libraries in the integration of the immigrants in the community. So next one, please. So this is the story of a mother and her baby becoming immigrants in the United States and how a library helped them integrating to their new community and the new country. Next one, please. So what was the role of the library in this story, and what should be the role of the library in helping our newcomers integrating into the community? So the libraries are called the third space, which means that this is a community safe space. It's a local space that will be, or the library should be knowing the needs of the community they serve. The library belongs to the community and should be responding to the community. So this is a space that provides that sense of sociality, in addition to home, which is the first space, and work that it's considered the second space. But recently, libraries, in addition of providing or helping getting knowledge, information, and imagination, they have included, especially the Highland Park Public Library, of the fostering of intentional connections with the community. So in this sense, libraries have become more than books. Next one, please. So in the story, at the beginning for the baby and the mom, the library could be perceived as an unknown space, something that it might be a little bit scary, something that it's new, as the book says, suspicious, like what is happening here. However, next one, please. The library is providing our immigrant community, in addition to books, a way to learn to speak, to write, but most important, the libraries are helping immigrants to make their voices, our voices, mi voz, heard. And how is this happening? How are libraries contributing to listening and helping immigrants to make their voices be listened? And what are they doing to help the integration of immigrants in the community? Next one, please. So more and more libraries across the United States are hiring social workers as part of their team. During our previous presentations, we listened a lot about building trust. And by hiring a social worker, that's one of the main objectives, that the newcomers, the immigrants, can also envision the libraries as a trusting space. As a patron may come, and they might be requesting maybe a book and some readers of advisory, and maybe the librarian will be asking, well, what kind of book? What are you interested to do? And maybe the patron might say, well, I'm looking for a cooking book because I might wanna do meatballs. And the librarian might say, well, tell me more about the meatballs you wanna cook. And the patron might say, well, maybe I want to recreate my grandma meatballs, and my grandma was from Italy. So the librarian might have a better idea about what cooking book to recommend to the patron. So something similar we wanna happen with our immigrant community, or anyone who might wanna know more or where to find help for any of their needs. And they might not get a book, or they might, but in addition to that, the social worker will point them out to specific resources. So some of the functions or the roles that the social workers in the libraries are doing right now is, number one, the community network. They're needing a support system, a local support system for our immigrant communities. And we want to foster and to reinforce those partnerships. As I was listening to people made visible and health navigators, this will be a great space for them to come and also connect with the community. The social workers will also be educating and in the navigation process of the different systems. For example, the health system that we already listened Nancy talking about it, and some other of our previous presenters, the educational system, financial system, etc. Programs, the social worker can also inform in a better way to the library about the different programs that we might need to create for the newcomers. This could be support groups, or this could be any other partnership with other community organizations to better help them in this integration. Referrals, we know that a library is not a social service agency, but it will be so important to have all these partnerships and point them to where they can get the help they need. Also, the social worker who help the libraries or are actually helping libraries, especially staff, getting the appropriate training and support to be better informed with a DEI lens, with a culturally relevant lens, and most important, with having a trauma-informed lens and moving the libraries to be a trauma-informed services space. But for all of this to happen, it's so important that this piece of the library, the social worker in the library program, is part of a strategic plan, and it's embraced by the whole library as a core piece in order to better serve the community. But we can talk a little bit more about these tasks that the social worker in the library could have when we have the support group. Next one, please. So this is happening all over the United States. If you go to that website and you can zoom on the different states, you will see what libraries are having a library social worker in their space, and specifically what services are providing. The DuPage Federation, in collaboration with RAILS, which is the Reaching Across Illinois Library System, they started a very important networking group that is called the Social Worker in the Library. And we have our first meeting with a very good attendance. I think I counted more than 50 participants of different libraries and social workers that they would like to collaborate. Next one, please. I want to give you a local example of the Highland Park Public Library and the Highwood Public Library. Highwood has been an inspiration for us in how they're working on equity help component in their library. As you might know, last year, Highland Park had a mass shooting, and it was it was a senseless tragedy. And as a response to this tragedy, we wanted to make sure that our immigrant community, who was also impacted, was informed in a culturally relevant way about the resources available and walk them through this healing process. So it's going to be a year that the Highland Park Public Library and the Highwood Public Library has created the Facebook Live Caminando Juntos. In the beginning, we were having lives every week after the mass shooting. Right now, we have them the first Monday of every month, and we are listening to what the community, especially our immigrant Spanish-speaking community, are struggling with, or they need more information about, or there's some stigma, and we invite guests to talk about it in a culturally relevant way. And this was created tapping into best practice that we had during COVID, on which we found that the Facebook Live was a very good way to keep our community informed about resources and about what COVID was about or what was happening. So we decided to replicate this model and now serve our immigrant community after this mass shooting. Interesting enough, the episode about the role of the social worker in the community is the one who has had the most views compared to the other topics that we have addressed. Next one, please. The Highland Park Public Library is also supporting the emotional health of the community by creating a section on their website about trauma resources. And the community, if English is not their first language, can translate the website, our website, using the Google Translate function. So there is a list of resources, and there's also a section to the right where there are resources for families, children, and teens that our librarians put together. Yet we also have programs. Yesterday, in preparation to the remembrance of the year of this mass shooting, yesterday we had a program with miniature therapy courses, and we promoted these in English and Spanish to benefit the community. We also have a program that, and with the support of the Friends of the Libraries, that it's called A Book for You, Un Libro para Ti. So we have books in English about trauma-informed or resources in this healing process, but we also made a selection not only about the translation of those books, but books of well-known and recognized authors and therapists in our Latin American countries, and we have brought them to the community. For our immigrant Spanish-speaking community, for example, the book El Camino de las Lágrimas by Jorge Bucay, they have been so surprised and grateful that we have these resources for them. And also we have started tours in Spanish, and today, actually at noon, we're having a tour for high school students who are newcomers to the community, and they can know more about the library. Next one, please. So what happened in our story? The library became the third safe communal space, so they can become something that they haven't ever imagined. Next one, please. So the mom and the baby, they're now stories, their two languages, their lucha, their resilience, their hope, they're dreamers, they're soñadores del mundo, they are love, they are amor. Y colorín colorado, este cuento se ha terminado. You'll find the resources at the end of my presentation if you want to know more about this innovation in the libraries. Thank you very much.
I'm giving folks a little view of those resources, then I'll stop sharing. Dr. Rosita Sheftel, thank you very much. What a vision for the third space as a center of collaboration, so that all of the sectors that are on this call have a place there to come together and support the community and be a part of that support. All right, I want to take a moment to check in with Rosa. Do we have questions that have been posted in the chat for our panelists?
We do not have any questions as of yet. So if anybody wants to go ahead and ask a question, and just use the double hashtag before you do so.
Well, that might be a signal to us, Rosa, that a lot of good information has been shared very effectively, and that maybe our group is ready for us to go right ahead and move into the presentation on policy and advocacy. And I'm so pleased here to welcome Luvia Quinones, who is the Senior Director for Health Policy at the Illinois Collaboration on Immigrant and Refugee Rights. We're so pleased to collaborate with ICER on advocacy initiatives, and I want to invite Luvia to come and give us an update on legislative policy and processes. And Luvia, let me ask you, would you prefer to advance your slides, or would you prefer for us to do that?
If you guys could go ahead, Dave, please.
Okay, give me just a moment to get that up.
Go ahead and start, Dave.
I'm just having to work my screen. I'm almost there. I think we're there. Thanks.
Great.
Are you able to see my screen now?
Yes, I'm good.
Good,
Thank you.
good, good.
Great. Well, first of all, good morning, buenos dias. Thank you for having me today. As Dave mentioned, my name is Luvia Quiñones, and I work at the Illinois Coalition for Immigrant Refugee Rights, also known as ICER, or ICIR, however you want to say the acronym. I'm going to be giving 3 legislative updates today. Some of these you may have heard of before. I want to first off start saying that as a coalition, all this work is done by and with our members. So we cannot do it on our own, and it's nothing like that. So even though you hear about ICER, just know that it's a statewide coalition. So I always want to make sure that we acknowledge our members, some which are actually here today. Next slide. So as I alluded to, the Illinois Coalition for Immigrant Refugee Rights, ICER, is a statewide coalition. We've been around for a little bit over 35 years. And our mission is to advance the rights of immigrants and refugees, as well as to defend many of the issues that we're hearing from other states, and trying to pass legislation, whether it be at the local, state, or federal level, and trying to see what type of different pro-immigrant policies we can create, pass, and advance for the better good of everyone. Next slide. So today I'm going to be talking to you briefly about some of our recent victories. 2 of them are legislative. I misspoke earlier, and the other one is budget related. So I'm going to be sharing with you a little bit about driver's license, as Kara had alluded to, our medical debt prevention bill, and then also some of the programmatic services that we provide through our program partners. I will say that I am not 100%, or I could say super knowledgeable on driver's license. I'm going to try my best. My colleague Fred Sau is the one that led that effort. I'm so happy to connect anyone with him if you guys do have specific questions that I'm unable to answer. Next slide. So some of you may be familiar that here in Illinois, about I think the first piece of legislation was passed about 13 or 14 years ago, where Illinois, we were very, very excited to pass temporary visitor's driver's license for undocumented. It was a very long journey. Many of you were involved. That advocacy organizing took over 13 years to pass that legislation. Since that, and again, it has been about 13, 14 years of that legislation being implemented, there have been questions as well as issues arising. You'll see in the next slide how the temporary visitor's driver's license, TVDL, look different from the regular driver's license. So after many conversations with our members, hearing about issues from our member organizations, we started seeing what were the options, what was the possibility of introducing legislation that would allow undocumented individuals and others to be able to apply for a regular driver's license. Keeping in mind that Illinois, similar to other states, needed to implement the Real ID Act. Here you'll see some of the other reasons why we started pursuing this. I'm not going to read them. I'm sure Dave and others could share with you the presentation so you guys could read them at your leisure. Next slide. So we wanted to show you the differences. So the top driver's license is the Real ID. Some of you may have it already. As you know, it has that little goldish white star that says that you kind of have gone through this whole the screening, et cetera. You're able to use it to fly, et cetera. Then you have the regular driver's license. As you could see, it does have federal limits, meaning, as a result of the Real ID Act, you can no longer use a regular driver's license to enter federal buildings, to fly, et cetera. Then you have what has been around again for about 13, 14 years, which is a temporary visitor's driver's license. As you could see in the one in the bottom, it has both one, that little purple line, which makes it stand out, and 2, it also says that it's not valid for identification. As I alluded to a second ago, those were some of the things that we were hearing from our members and from the community that were becoming issues. Unfortunately, depending where in Illinois a person was driving, sometimes a cop would would pull them over, etc. And despite it being against the law, the cop could potentially ask more questions, etc. That could create fear, create many issues, because again, the driver's license looked different. And for some people that have nothing else besides a TVDL, they were not able to have anything to prove their identification. Again, because the license does say that it's not valid for identification. So that led us to introduce legislation for people to now apply for both a regular driver's license, so the one in the middle, as well as being able to apply for a state ID. Next slide. So before I get into this one, I thought I had included another slide. So apologies, I'm not seeing the other slide. I will say that we were successful in passing this. I believe it's towards the end, so apologies that I put it towards the end of the presentation of when it takes effect. But thanks to many of our members and other allies, we were successful in passing the legislations for driver's license. I'll tell you in a second, I believe it takes effect July 1st of 2024. So starting then, undocumented individuals will be able to apply for both a regular driver's license, not the real ID, because that has a whole nother set of federal regulations, but they'll be able to apply both for a regular driver's license and a state ID. Which is going to be the first time many individuals are going to have either of those documents. Again, if you have any specific questions, feel free to reach out and I could connect you with Fred, our senior policy counsel. If it's other, you could say more straightforward questions, feel free to put them in the chat. The next thing I'm going to share is another legislative effort that we led along with our members. You heard a little bit from Kara of kind of all the reasons and all the issues that uninsured have when it comes to accessing healthcare, and how unfortunately many individuals end up with medical debt. I will say that in our experience over the years, what we have been hearing from many of our members and allies is these individuals that end up with medical debt are actually eligible for something. They may be eligible for some type of Medicaid. They may be eligible for financial assistance, also known as charity care. But unfortunately, how the state law is written right now, it puts the burden on the patient. So it pretty much is there, the hospitals and other, you could say, people are expecting the patient to know about all the existing programs, about all the existing laws. And in the immigrant refugee community, as well as other communities, many of them are not aware. As you heard from Nancy, there's language barriers, there's fear and mistrust, there's lack of information, etc. So we decided along with our members that wouldn't it be great if there was something that would require hospitals to screen uninsured. So after many conversations with our members and partners, we started looking at other states. There's 3 other states that have similar laws, and we introduced legislation back in January that would require all hospitals in Illinois to screen uninsured for available health programs. And these programs could be anything from public health insurance, whether it be some type of Medicaid version, whether it be if they're eligible for the Affordable Care Act, or if they're eligible for hospital financial assistance charity care. Next slide. The legislation that we introduce, not only will it prevent medical debt for uninsured, from our perspective, it could also improve health outcomes for uninsured. As you heard from several of the panelists today, people end up foregoing care. They're so afraid of ending up with a hospital bill that they cannot pay, that they end up either waiting too long or they go from an acute illness to a chronic illness as a result of not accessing health care. So that from our perspective, this legislation could also address some of those concerns. And lastly, we, in our perspective also, providing the legislation could also help when it comes to hospitals being able to get reimbursed for certain things if they actually start screening individuals. So very, very high level summary of what the legislation will do. Next slide. So when it comes to the medical debt, again, you guys will get more of the specifics in next steps, but we were successful, similar to the driver's license bill, and it did pass, so it will become effect in January 2024. So it's a different date. So the driver's license will be July 1st, I believe. I'll double check once I get to the slide, but I believe the driver's license is July 1st, 2024, and the medical debt will be January 1st, 2024. Thanks to, again, a lot of the advocacy that was done by some of the organizations here, as well as many of our members, that now hospitals are going to be required to screen all uninsured. And for people that are found to be eligible for charity care, hospitals are going to have to be assisting them with the application. If they're eligible for something else like Medicaid, or the Affordable Care Act, known as Obamacare, then the hospital will connect them to the appropriate institution, whether it be an FQHC or whether it be a community organization. Lastly, I know that that many of you have been getting questions or have been directly assisting the recent arrivals, sometimes also referred to as migrants, also sometimes referred to as asylees. So wanted to make sure you were aware of the various programs that we have, not that we have all the services or all the programs, but we have a couple of different things that could be of help. These programs are for a couple of different immigrant statuses. So for people that are looking to apply for citizenship, and also for people that are looking to be connected to various health and human services in their own language. So through the Immigrant Services line item, also known as ISLE, these set of programs have been around, some of them for about 15 years, some of them close to 25 years. We have these, so we have the New Americans Initiative, which assists people that have a green card to apply for naturalization. We also have the Immigrant Family Resource Program, IFRP, that assists people that are limited English proficient to apply for various health and human services programs. Through IFRP, through our partners, I should say, through IFRP, they have the language capacity in about 55 or 56 languages. Next slide. Now, when it comes to the next steps I alluded to, I was correct. I was trying to remember the date. Again, the driver's license legislation will take effect July 1st. So that would be the earliest somebody could apply for both the driver's license as well as state ID. And the medical prevention legislation will take effect January 2024. Next slide. I also wanted to make sure that we mentioned through the ISLE programs, we also, through our partners, we also have some scholarships. One is for people that may not be able to pay the naturalization fee. For those of you that don't know, I haven't looked recently. Those that are familiar, Nancy or others, I think it's close to 700 or a little bit more. Thank you, 725. If it moves around, last time I worked on this was like 685, so it unfortunately continues to increase. And then we also have scholarships for DACA. The scholarships are based on depending on the income level and a few other factors. And there is a certain amount that is available for those. Some of the other additional services through the IFRP program that we have been adding, especially the last 2-3 years, is for some of you could say the newer communities, whether it be Afghan, Ukrainians, as well as the southern border arrivals. If you want to get more information, whether it be one where the organizations that help with these various services, I did put a link at the bottom of this slide where you could either print or just look at the various organizations that could help people through with naturalization, with citizenship, or also through the IFRP program. For the scholarships, that would be through the NAI program. And again, we have a list of the program partners that are statewide for both programs. Next slide. We also wanted to make sure that you were familiar with the various web pages that we have on our website. So the first one is our policy platform. So it has a little bit more details of the different things that we work on this past legislative session. The second one has various helpful fact sheets and other resources in various languages around health access. For the citizenship program, the New Americans Initiative, I put the webpage there, as well as for the IFRP webpage. Just if anybody's interested in learning more, or again, if you get a question of somebody that needs assistance. Next slide. So I think there were 1 or 2 questions down, but you want me to go ahead and jump into those, Dave?
Please.
Okay. Let me find the first one. Okay. So one of the questions is if this bill includes underinsured. So when it comes to state law is only able to address uninsured. And the reason is because hospitals that are not-for-profit do not pay property taxes. And as a result of not paying property taxes, they're supposed to provide financial assistance to uninsured individuals. That doesn't mean that hospitals cannot provide the same to underinsured. We're just not able to regulate hospitals in the same way when it comes to underinsured. For those of you that are not familiar, underinsured is referring to people that may either have a high deductible or sometimes the co-pays are very high. And the person has insurance, but unfortunately the deductible and the co-pays makes it very difficult for them to access healthcare. So again, the medical debt legislation doesn't address underinsured because we were not able to, but there are some hospitals that do provide charity care hospital financial assistance to those individuals. The other question is if there's funding tied to the mandatory screening for hospitals. No, it is not. As everyone knows, passing things in Springfield related to hospitals is very, very challenging. For those of you that are not familiar, it's just very difficult. We actually weren't sure we were going to be successful this year. So we had to keep the legislation high level, meaning somewhat at a minimum when it came to the screening. We know that hospitals are going to be implementing this legislation differently. So we are starting the conversations with the Illinois Hospital Association to see what type of training they're going to be providing to their members and exactly the how and the when. So that's all to say that there's no funding. So they're going to be implementing it differently. Currently, as an example, Rush Hospital has been doing this already for a number of years, and Rush Hospital has a good number of community health workers, promotoras de salud, in the ER that assist with this. Other hospitals may do it differently, but again, we'll be learning about the implementation as we continue the conversations with IHA, the Illinois Hospital Association. Another question is, so why do hospitals like Amita get away with limiting access to Medicaid patients? Christy, if you'd like to share a little bit more, I know that a number of years ago, there were a lot of health access issues for people with Medicaid because the state was behind on reimbursements. To my knowledge, that hasn't been that much of an issue. And I do want to say that regardless of the insurance, no hospital, no provider can turn away a person. So if there are either specific examples and you would like to chat some more, happy to discuss that and see if there is some advocacy needed around that, either with HFS or with the Attorney General. And I'll make sure to put my email in the chat.
Luvia, thank you very much. And I also want to touch base with Rosa. Are there any other questions that have appeared that we should be addressing?
It looks like those were the only questions so far.
Very good, very good. Luvia, thanks so much for that update and for giving us steps that we can take to follow up. note that there is a poll that's come into our screen that is asking about use of the language room. So if you would please respond whether or not you require this language room. That would help us in our planning for what's coming next with the breakouts. As that poll is moving forward, let me do a couple of things. First of all, Luvia Quinones, Dr. Carrie Rosita Sheftel, Nancy Garcia, Kara Murphy, Sarah Phelan. Thank you so much for filling us with good information. And it's amazing to see the way in which each of you shared something that was connected to or supported by what others had shared as well. Your wisdom, your leadership, your principles in moving forward are a great help to us and a great inspiration. Thank you for being here this morning. I do want to invite Rosa to drop into the chat a link to one of the resources that is embedded in Luvia's links at the ICER website, and that would be the link regarding public benefits access. There is a wonderful resource available at the national level regarding public benefits eligibility by immigrant status. And it has been recently updated, and we want to commend that to everyone here. So now we're going to move into the part of our meeting where we learn from each other, where we get a chance to do our own trust building, and we get our own opportunity to share the things that are working in our community that we want others to know about. We're going to move into breakout groups. And I want to invite Danica to the microphone to guide us through the breakout group process.
Good morning, everyone. We are about to share the link to the Jamboard in the chat. I do want to make sure that you all have a chance to launch the Jamboard before we break out into the breakout rooms. If you need any assistance, you're more than welcome to send a message directly to me, but the assignments will be at random. If you did select the option to say that you are using the interpretation services, please let me know so that I can put you in room 1. Room 1 will have the interpreter if you would like to continue using that service. Does anyone have any questions before we begin?
Danica, I might add on that so we'll be breaking into groups of 8 to 10 people, and each group will have a Jamboard available to them. So those Jamboards will be numbered 1 through 10. As Danica mentioned, the first Jamboard, number 1, will be for the Spanish language breakout group. And as you're assigned randomly to a group, whether that's 2, 3, 4, and 5, note the number of your breakout group, because that's the number of the Jamboard that you should navigate toward. Not everyone on this call is proficient at Jamboard, and if you're not, ask you please don't worry about it. Go ahead into your breakout group. Use the breakout group as a time to get to know others who are there. And I do ask those who are proficient or skilled at Jamboard to please be an aid to your other group members. We won't have a facilitator in every group. We ask that that be raised up naturally from within the group. The Jamboard itself has 5 key questions that we're asking you to use to guide your discussion. And it's now 10:24. We're going to stay in the groups for about 25 minutes. So at about 10:50, we will welcome you all back to the big group again. And I want to check in, Danica, back to you regarding, is there anything else that we've missed in terms of the guidance here?
You can find the group numbers in the bottom right corner of the pages for the Jamboards. So again, just make sure you navigate to the appropriate group number. For those of you who are still in the main meeting space, have you been assigned to a group or just chose not to join the group?
Can you sign my group again? I'm sorry. I leave accidentally.
Okay. Is there anyone else who needs assistance being assigned to a room?
Yes, I
Perhaps
do, please.